pregnant woman who's come in, let's say that she is close to 40 weeks and therefore she's in the third trimester, and it turns out she came in because she had this recent contact with a patient, with not a patient but a relative who had chickenpox or varicella, and then that patient eventually got treatment, and therefore the recent contact happens to be a confirmed case of chickenpox. And because the woman is pregnant, she got concerned, so she comes in to you. And then what's your plan here? Your plan is to first run an IgG antibody titer, and let's say it turned out to be negative. If it's negative, you'd want to make the decision to go ahead with passive immunization with varicella zoster immunoglobulin. Now, if it turned out positive when you have confirmed the infection, you would go towards a medication such as acyclovir. But the fact is, acyclovir, its its it, its role or its role in preventing chickenpox is not known, and there aren't any well-controlled studies to definitively say that it is actually safe to give acyclovir during pregnancy. And therefore, since this patient is negative, your first step would be passive immunization of the patient with varicella zoster immunoglobulin, and then you're going to give the patient 125 international units per 10 kilogram of body weight for the pregnant women, and then to a maximum of 625 international units of varicella zoster immunoglobulin. And this would be a general approach to a patient who had a recent contact with a confirmed case of chickenpox. The reason we want to go ahead and give the varicella zoster immunoglobulin is because varicella zoster, this virus can cause complications to the patient as well as the neonate. So for the pregnant women, we are looking at pneumonia, encephalitis, and the varicella, neonatal varicella manifests as a rash, a superinfection with bacteria and a rash. And therefore, you'd want to prevent the onset or the severity of how varicella zoster presents to the patient by giving this passive immunization. Thank you.